Good morning, good afternoon, good evening, and good night to all colleagues and friends from all over the world. I'm very happy that we are now beginning the fourth episode of CPD Talks with a great name from Canada, dear Professor Lawrence Yanover, a great clinician, an eminent name of pediatric dentistry, an educator, a teacher, a clinic chef, and I think a real mentor for all pediatric dentists. Dr. Lawrence Yanover, welcome to the CPD Talks. How are you?
I'm fine, thank you. It's lovely to join you today.
Yes, thank you very much. What time is it there right now?
2 o'clock.
2 p.m.
Yes, 2 p.m. Not too bad.
Right. Here is 9 p.m. in Turkey. So I will introduce you to our colleagues, and then we're going to begin question answers. Dr. Yanover is a distinguished figure in pediatric dentistry with an extensive experience and a deep commitment to the children's oral health. He is a world renowned for his wisdom and expertise. His approaches and compassionate care have positively impacted many of young patients and shaping the field of pediatric dentistry. It's my privilege to be in the CPD talks with such a great, respected individual whose dedication to the well-being of children's smile is truly exceptional. I will very shortly introduce the important remarks of Dr. Yanover. He has been practicing a pediatric dentist for over 40 years with extensive experience in private practice and hospital dental care. He is the past president of the Canadian Academy of Pediatric Dentistry, and he has served organized dentistry within the Ontario Society of Pediatric Dentistry, Ontario Dental Association, and Royal College of Dentists in Canada. This is what we know about you, Dr. Yanover. How would you describe you with your own words?
I consider myself such a lucky guy because I graduated, I had just turned 23 years old. Now, in North America at that time, that was young. Nowadays, it's even younger. I don't know about Europe and other parts of the country, but I got into dental school after 1 year of university and graduated, which is unusual. Most people got in after 4, and then I graduated very young. So I had one thing that most people don't have, and that was time. So I realized that I had a lot of years that I could spend doing things other than being in a dental office and providing treatment. So my mind was open to every possibility, and I was very excited to try my hands at everything. Clinical dentistry, academic dentistry, research, hospital, and organized dentistry. And those are all things that that people should open themselves up to and think, all right, you could spend the next 40 years in a clinic in a 10 by 10 box and have a very nice life and go on from there. But I think it can get a little bit boring, and it's a lot more fun. And you know, because you're in academics, because, to expand your horizons, to meet people around the world, to be able to teach and do research and so forth. So the first thing that I did, I had great experience as an undergraduate with some great clinicians who were also teachers. Now, in those days, you could be a clinician and then go into a teaching stream. In those days, it was very normal. So most of the people in the university had been clinicians, retired from clinic, many of them from the military after 25 years came into the university and had a pension and could very comfortably live on the pension plus what they did, plus their teaching. This doesn't exist anymore. So what we have now in the university is people who are mostly researchers with very little clinical experience, some of them, many of them not even dentists, and the only clinicians that students really meet are people who, like me, who basically volunteer their time a day a week and provide clinical experience. And I think that, at least in North America, is a great loss to the dental schools. Because I think you have to graduate actually having to know how to do dentistry, not just thinking about how you could do dentistry. So this has been amazing for me that I had the opportunity to do all these things because it was, you know, life was inexpensive in those days. Everything was open to me. Nowadays, life is so expensive. You graduate so much later, and you have so many challenges if you've got a wife and a family, and academic salaries are not very good anymore compared to the expenses of life. So I consider myself so exceptional in having the opportunities to do whatever the heck I wanted at that time, and it's been a very fulfilling career.
Yeah, you're very lucky to have such a great career with very different pathways to the success. So let's begin with the first questions. All right. With a career spanning over 4 decades in pediatric dentistry, your journey undoubtedly mirrors the remarkable revolution of the field. Could you offer us a glimpse into the pivotal change you have witnessed and how they sculpt your practice within these 40 years? So here is the question. Sorry. After 40 years, what pivotal changes have shaped your pediatric dentistry practice?
Sorry, can you repeat the question a little bit?
After 40 years, what changes have shaped your pediatric dentistry practice? Some remarkable.
Okay, so this is awesome, an awesome question. So when I graduated, we knew that standard steel crowns and pulpotomies were successful because I graduated from dentistry in 1977 and from pediatric dentistry in 1983. So at least we knew that. Access to general anesthesia was almost unheard of. The use of even moderate sedation was almost unknown, at least in Canada. I think it was being done more in the U.S., but really not in a very predictable fashion. And I had the unbelievable opportunity of working with Dr. Jerry Wright. So I graduated from University of Toronto. My academic career started at University of Western Ontario under Dr. Gerald Wright, who was an absolute leader in dental sedation and behavior management. So I worked in his clinic, plus I was in the academic program. I was teaching in the pediatric dentistry program. So what an amazing way to start a career to deal with one of the world leaders in behavior management. But in those days, literally, we had nitrous oxide, and then we had a lot of, chlorhydrate, diphenhydramine, dibenhydrinate, nisental, a lot of different things all over the place, most of which worked out to not be particularly good or particularly safe. The worst one was nisental, which eventually led to some deaths. It was a very strong opioid that was injected sublingually, and it created problems. So the biggest change for me was learning how to work with nitrous oxide, how to add 1 or 2 sedating agents, and then of course the ability to access general anesthesia. Now again, in Canada, initially general anesthesia was only offered in a hospital setting, as it probably was around the world. And then we had the ability to go into clinics, private clinics, where anesthesia was available. So we had that access. And then finally, we had the ability to bring a dental anesthetist or a medical anesthetist into our practices who would provide the anesthesia in our office and allow us to be able to do many procedures while the patient was asleep. So this also created, there was also one other drive for this. When I started out, if you told a parent we're going to do some procedures. Hello?
Yes, can you hear me?
Oh yeah, I can hear you. Okay, so we started out.
Yes.
You could do some procedures, and the parent said, "Fine, we can bring you back for 2 or 3 or 4. The child back for 2 or 3 or 4 visits. They're going to cry, but that's okay. We're okay with that." Children were a little bit tougher. The parents were a little bit tougher. I think the concern as we got older is that parents had very little tolerance for children being restless or upset in a dental office. And honestly speaking, for all of us that have worked in pediatric dentistry, first visit can often go very well, leave with some nitrous. Second visit, maybe okay. Third or fourth visit, kids' behavior tended to deteriorate. And parents became much less tolerant of that deterioration behavior. And I think, so, we had two things happening. Parents being less tolerant, children being less tolerant, and the ability to have the access to general anesthesia. So those have led to a huge change in pediatric dentistry, where more and more kids are being put to sleep, at least in North America. That also coincides with our ability to provide dentistry that we never had imagined possible previously. That is predictable restoration of anterior teeth, which to get a good result, especially with zirconia crowns, which now are available and which I did some research on, you generally have to have a patient who's very compliant, which often means general anesthesia. So the sophistication of what we were attempting dramatically increased. The parents' tolerance of their children crying dramatically decreased, and the ability of children to tolerate many of the procedures we do decreased. So all of those things kind of came together, where we now have a situation where general anesthesia, even in countries like I'm in contact with Sanjeev Paul, and we see that he's doing general anesthesia in his practice. He's very active in teaching nitrous oxide in India, which has become much more popular, which was unheard of 10 years ago. So there's been a worldwide change in our approach to children. And I actually think that's good, because one other thing that's happened with being in 40 years in practice is you start hearing from some of the parents that you treated many years ago. And some of them confess that they were distraught, upset, and maybe, I hate to use the word, but traumatized by some of the things that we did and thought were acceptable 30 or 40 years ago. And we're learning that now because those parents are vocalizing their anxieties about dentistry. And so I think we've learned a tremendous amount, and I've seen that change in 40 years. So those are the things that I think are the number one dramatic change. Like I said, the ability to predictably restore anterior teeth, the use of general anesthesia, deep sedation, and of course, the point in my life where I had to go from amalgam to composite, which was a big change for me, but because almost no parents in North America now will tolerate us placing amalgam in the children's teeth, even though I think it's an acceptable material. That also requires a more compliant patient in order to have a dry field, and it's procedurally more challenging. So all of those things require us to have greater skill levels and a patient that is more compliant to more sophisticated techniques and materials that we're using. So I would say those are the most important things that I've seen in my lifetime.
Yes. Is there any legal procedure for using nitrous oxide sedation in private clinics in your country? What are the requirements for this?
So this I can answer to you. Now, our country is divided up into provinces, and each province is responsible for its own healthcare. So it is not centrally dictated like, for instance, the UK. It's more like the United States, where each state has a decision about how healthcare is provided in that state. So in Ontario, we have very clear guidelines. You have to have a certain amount of training, and you have to, for children 12 and under, you must have the training, plus you must provide 5 cases. You must do at least 5 cases a year to show that you're keeping up with that training and experience, and you have to be registered with our college and have a specific license to be able to do nitrous oxide, so that they know that you have had that training, that you've checked that you have the training experience. So that's in Ontario. We have very detailed guidelines about emergency kits, about the setup, about safety, about the certification of the equipment, and it's very heavily controlled. But we are allowed to do it, and I know in certain jurisdictions nitrous oxide is not allowed in a clinical setting in a dental office, which I find shocking, because it is a very, very safe sedative agent. It is very effective, and I tell most general practitioners that a great number of your children would benefit from nitrous oxide, and that would minimize the number of referrals you'd have to make to a pediatric dentist. And when I teach my CE courses to general practitioners, and I just finished one on Saturday, I go into that in great detail, and I reassure them that for the ones that nitrous oxide isn't successful for, that's when you want to make a referral to the pediatric dentist. So it is an amazing tool to have in your armamentarium, and to either take some training, and then and then get some experience, get the equipment, get the experience. I think most general practitioners and those dentists, pediatric dentists, many who didn't have training in nitrous oxide, which I did not have very much of when I graduated in 1983, it is probably the safest and most effective first line of defense for being able to get a predictable result with anxious children.
What about the emergency situations when facing in private clinics? Do all dentists, pediatric dentists who are using nitrous oxide have ability or education to handle with emergency situations? What do you think?
All right, so our college, the Royal College of Dental Surgeons of Ontario, has published guidelines for the emergency equipment that has to be available for what we call minimal sedation, which is nitrous oxide alone. I'm not talking about nitrous oxide and any other oral medications or any IV, any other drug at all, for nitrous oxide. So if you look at the literature with nitrous oxide, you will find that if you're staying within the guidelines of, using somewhere between 30% and 50%, the only side effect is nausea. That's it. And it's a very safe drug. It's easily reversible. So you're not going to run into any significant problems. In my entire career, I have never seen, other than some cases with nausea, that you're going to have any significant side effects. And I would say that the literature would support that. Once you're getting into anything over 50%, then you've got some issues. The other thing with nitrous oxide is you must have the ability to scavenge the nitrous oxide, because the risk is not to the patient, the risk is long-term exposure to nitrous oxide to the dentist and their staff. So there are excellent scavenging systems available. We also have excellent ventilation put into our offices, and we've tested our office to make sure that there is minimal amount of nitrous oxide in the environment when we are using it. So those are important criteria to understand if you're using it. It's the patient safety is paramount, but it is the risk is absolutely minimal, and the most important thing is that there's the safety to the dentist and to the staff because of long-term low-level exposure.
And maybe it also depends on the case selection, right?
Well,
should be very careful on case selection for nitrous oxide sedation.
Yes, nitrous oxide sedation case selection is important, but that's not for safety issues, because again, anybody who's ASA1, ASA2, maybe even an ASA3 could tolerate it very well within the limits of somewhere between 30 and 50%. And and you're also going to you'll have a pulse oximeter if you want a pulse oximeter. They're so inexpensive now, and they're easy to use. You take blood pressure preoperatively. You've taken complete medical. The thing you want to know is, will the nitrous oxide work? And with a child with some minimal anxiety, and I would tell the general practitioner, if you can do an examination and you can get x-rays with that child, more often than not, the nitrous oxide is enough to be able to get effective minimal sedation. If you can't get x-rays on a child, if they will not open their mouth to let you do an examination, I would say at that point, it's very clear that nitrous oxide is not going to be effective in providing any care. So that's the guidelines. Can you take x-rays? Can you have a conversation with that child? Will they open their mouth? Will they let you do a thorough exam? Did they have issues at another dentist? That's the other important point. Do they have issues with the other dentist? How are they like at school? Do they have any issues at school in terms of behavior? So that's part of the social and behavioral history that you're going to get for that child before you do that. But I also say that if you're not sure if nitrous oxide will work, it's worth at least trying it. If they meet some basic criteria, like you can get an x-ray, you can get a proper diagnosis and treatment plan, then your first defense is try nitrous oxide. If it doesn't work, you have the opportunity to explore other options, but it is the safest and the least invasive of all the procedures that we can use to modify a pediatric patient's behavior.
As I know that oral sedation is very famous in India, in some countries. What do you think about oral sedation?
All right, so we do oral sedation routinely in our teaching program. Now, I'm going to tell you that oral sedation is one of the most disappointing experiences you are ever going to have in a pediatric dental environment. So, in my career, midazolam, of the new modern drugs, midazolam was the first one that was introduced, and it's still used off-label, as we know, for behavior management in children. Midazolam, given at appropriate dosages, such as Malamed would suggest and others, you can get about 15 to 20 minutes of effective behavior management in about half the kids you're going to give it to, even if you're fairly careful about your selection. The other half, you're either going to get no effect or the opposite effect. So in my books, a 50-50 shot at a good result is not great. So then you get into higher dosages, which lead to some significant issues with midazolam, because it can cause some respiratory depression. It doesn't taste very good, which creates another question. One of the questions I ask is, how is your child at taking oral medications, such as Tylenol or Tempra? If they're not great at taking oral medications like amoxicillin or Tylenol or Tempra, you're never going to get any midazolam in them. And the only midazolam that works is the one that is taken in the mouth and swallowed. The one that's spit out onto the floor, it's not that effective. So that's the first thing. What's the behavior like? Will they take an oral medication? So then you get into the dual medications, midazolam and ketamine, which is the most common one. Or you get into the triple cocktail, which is Phenergan and dimenhydrinate and something else, which has some reasonable success. And Stephen Wilson teaches that, a very good program, which you can go to the States. I know he offers it in the States, and I've done the program on pediatric sedation. Excellent program. But again, it's hit and miss for them. And the other point that's very important is what we define as success and what a parent defines as success is very different. So our success might be the kid was crying. He's not going to remember very much. We had about 20 minutes of treatment time. We got a couple of extractions done and maybe a single crown. And great. Now, the other part of that is, were you holding the patient down, or were you using a papoose board? In Canada, the use of a papoose board is very frowned upon. In my mind, if I'm doing oral sedation or any kind of sedation, the only way I can safely monitor that patient with a pulse oximeter, with blood pressure cuff, is with active restraint, which means a papoose board. That creates a great deal of difficulty for many, many parents. In other countries, it's not an issue, but in Canada, it's not considered great. So then you get these situations where you're actively holding a kid down while you're getting some treatment done, and you know they're not going to remember very much. They're struggling, meaning they're crying, they're moving around, but you can get what you have to get done. Now here comes the other part of it. Do you let it keep a parent in a room, or do you not let them in the room, which is a whole nother area of discussion. If you have parents in the room, the modern parent will see that struggle going on and thinking the sedation is not effective because they're seeing the child respond. And children will respond. They are not completely asleep. They are responsive. They won't remember very much, and they're doing better than they would without any medication. But that's not what the parent sees. And then if you don't have the parent in the room, then they're hearing some crying sometimes, or they're wondering, what is that dentist doing in the room to my kid that I don't know about? So this creates a whole other set of issues which are interesting to explore. Again, when I talked with my residents, we just had an example yesterday. We have many complaints that to go to our college, and this doesn't happen in many other countries, but Canada is extremely highly regulated, and in Ontario we have a very active college that takes every complaint, no matter how frivolous, very seriously, and then you're in for 3 or 4 years of a legal battle with our college. So if there's any parent that is in any way upset or worried about the treatment they receive, you're going to get a complaint to the college, which is going to tie you up for 5 years with legal battles. This is how we practice in Ontario. So that brings us to the point of, is oral sedation effective? Sometimes, not predictably. Is it a good choice? Sometimes, with the right parent, having explained to them how this oral sedation will work. It's going to sedate the child. It is not going to make him non-responsive. That's a general anesthetic. So, do you understand that? Are you willing to go ahead? It's all about informed consent. And the more informed the parent is, the more effective the consent's going to be, and the better our treatment choices are going to be.
Great. Great knowledge. Thank you very much. Great experience. Very long question, and we are now passing to the second one. Within all our careers, within our journey, we got many lessons from our teachers, our friends, our patients, our parents, as you know. And here is the question. In your extensive career, what's the single most valuable lesson learned? Do you remember any most significant one?
Yeah. Talk to the parents. Listen to them. Understand them. Understand their fears, their anxieties, their issues, their traumas. And again, yesterday we had a situation where the young resident was dealing with a parent who's extremely aggressive and extremely vocal in the issues that they had with how the treatment was being performed. It was a cementation of a space maintainer, and he was claiming that the child was in pain, and I had to be called in to intervene. Which when you're dealing with graduate students, you only you discuss before, you discuss after. You don't generally want to intervene in the middle, but I had to intervene. And I spent about 15 minutes with that parent, and we talked about words like pain, and what we were doing, and is it painful, and what does pain mean, and how pain is everybody feels pain differently, and everybody has different levels of pain for a given stimulus. And the first thing I did is I acknowledged his concerns. And I said, I acknowledge and I respect your concerns, and I'm going to do everything I can to do what you want me to do to manage this situation. Because it's very important for us to provide great care that you accept, and that your daughter is not, traumatized by. And I use that word loosely, but for us, I've been doing this a long time, and what we did 40 years ago, what we do now, and what patients and parents will tolerate is very, very different. And at the end of about 20 minutes, we had him turned around so that we came up with a compromise that was acceptable to the parent, that was acceptable to the 7-year-old that, was very fearful, and which established that we could get some treatment done that was positive for the child. So, boy, if you don't have the parents on side, the parents they control everything. At least, it's a very different situation than in some other areas where, the parent would come in, if the doctor says do this, this is how it's done. That's not what happens in North America. The parent has the ultimate decision-making authority over everything that you do. And the one job that you have is to win the parents over, to make sure that they're confident with what you're doing. And I would say the greatest failures that I had in my career are angry parents who I didn't manage in a way that was really satisfactory. And that's why I work very hard at trying to win over parents, because those are the greatest disappointments I've had in my career. I don't care if the dean is mad at me. I don't care if other people are mad at me, but I hate, when I'm dealing with a family and a parent is mad at what I've done.
We are exactly looking from the same mirror to behavior management. We cannot exclude parents apart from the behavior management. I would like to ask something about this. No, we can pass to other question. I will ask at the last part. Dentistry is an evolving discipline, as you know. There has been many advancements or technologies from all over the decades, as you know. So here is the question: which groundbreaking advancements transformed pediatric dental care in the last decades? Like MTA, other things. What do you say?
I'm going to give you 3. So certainly, predictable pulpotomies is definitely one of them, because all of us are presented with extensive caries, which most teeth require pulpotomies. So even though formicresol is an excellent material, it is now not really accepted because of the carcinogenic risks. So the use of the predictable MTA, and especially neo-MTA putty, which is so amazingly easy to work with. The old MTAs where you mix a powder and a liquid, they were terrible to work with. But for pediatric dentists to have a predictable material that does not stain dentin and enamel, such as neo-MTA putty, and again, I have to say that is a great product from New Smile, and they don't pay me anything to say this, but anybody who's used it, I brought it into the clinical atmosphere in our university, and from the time I brought it in 1 year ago to now, it has basically been amazing. And we've even given it to the endodontists, and they're excited for its use because what they used previously was terrible, and they just love this stuff. So, pulpotomies, MTA, absolutely, especially the putty, the use of the putty, it's fantastic. Ability to safely perform general anesthesia is a game changer for pediatric dentistry. The third thing, when I give in my full day lectures, and I talk to a great extent about anterior restorations. So when I started out, here's what we had. We had, predictably, you could extract those 4 front teeth and put in a groper appliance, which is a space maintainer with 4 teeth glued onto them. That was state of the art. Then we had stainless steel crowns. You could cement them, cut out a window in them, and put in some resin, and they looked okay and they actually stood up reasonably well. We also had polycarbonate crowns, which was used in permanent teeth for interim, restoration before a bridge was placed. I did them. They were terrible. They looked great the first day they were on, and they all came off shortly thereafter. They're still being used in India, I understand, because I've seen some research out of India. Then we had strip crowns, which were made famous by Bill Wagner, who's a friend of mine and probably one of the greatest clinician educators in the world today. And if you get a chance to talk to Bill, please do. And of course, his work with Ari Kupetsky out of Israel is groundbreaking. Please, if you ever get a chance to work with Ari, what a delight! What a great researcher. He took over the second edition of Behavior Management in Children that was originally published by Dr. Jerry Wright. So it's very interesting that I practiced under Jerry Wright, and I was friends with him for many years, and then I became friends with Ari Kupetsky, who brought me into the IAPD as well, which is also fascinating. So that's our ability to then do strip crowns, which were aesthetically very nice, and under ideal, exceptional conditions, they lasted pretty well. But as pediatric dentists, we didn't get those situations very often. And if you go and look in some of the things that I see posted, where people are taking very small stumps of teeth and doing pulpectomies and strip crowns on those teeth, my experience is not as good as at least the pictures that I see, meaning usually those are going to last 6 months if you're lucky. So you've given a kid a sedation or general anesthesia, a great deal of cost and whatever, and my feeling is that maybe that's not the greatest choice. But once we got into zirconia crowns, which I first saw at the New York meeting of the American Academy of Pediatric Dentistry by Sprague, which was not, it was at that time wasn't called Sprague, but is now Sprague. That was the first time I saw zirconia crowns. I said, what is this? I don't understand it. I don't know anything about it. And then I started learning about it. And eventually I took the training through New Smile, and then I did my studies. And only after I was assured myself that these were incredibly successful, like nothing I'd ever done before. Now, I have to say there was a little window in there where I did pre-veneered stainless steel crowns for about 10 years, which I had very good success with, although the veneers did come off sometimes. To my, in all the years of doing zirconia crowns, I have not seen anything which lasts as well in the anterior. Now, in the posterior, they're much more of a challenge, and I will do them very selectively, and they're a lovely they are a lovely option in very skilled hands, done under ideal conditions. Bioflex, I don't know how good they are, because again, I say it's a plastic material, not that much different from polycarbonate. And having grown up in the era where I did polycarbonate crowns, I'm not that. I don't know. I think they're a nice interim measure. I'm not sure that they're a great long-term. They won't have the long-term success that stainless steel crowns do. But I'm holding my breath on that one. I want to see some good clinical evidence, in vitro and in vivo. So those are the three things: predictable anterior crowns, successful predictable pulpotomies, and the safe and predictable use of general anesthesia. I think those are the three things that have made pediatric dentistry an amazing field nowadays.
As you know, I am the president of the ICCPD. We had hosted you, and you had given a lecture in 2021 in my Congress,
right.
International Congress of Contemporary Dentistry. 2 years ago, in 2022, Anna Fuchs, the professor Anna Fuchs, and Caroline Primus, as you know, the inventor of NeoP2 MTA, they had given a joint presentation in our Congress. I would like to tell this. Another thing, I want to ask right now. Nowadays, we see a Hollywood smile in very young children. Zirconia crowns between canines,
right.
and SSC for all molars. This is very popular in Turkey and also in the world.
Yes.
What's your protocol? I am talking about general anesthesia. If a child comes into the operating room, should we put zirconia crowns for all anteriors and SSC for all molars? Is this your protocol?
This
Or
is
what do you
my
suggest?
protocol. So they come, it's obviously going to be a general anesthetic. We're looking at a 2-hour general anesthetic. We're going to do stainless steel crowns on all the posterior teeth and pulpotomies as needed. Based on the parents and their the levels of coverage and cost, I will consider stainless steel crowns on the lower cuspids. Some want them, some don't because they're a little more visible. I will not put veneered stainless steel crowns on those two teeth because the veneer comes off very quickly due to function. Veneered stainless steel crowns do work very well on the posterior. There is a little bit of occlusal wear, but predictably they're quite good. So I have a lot of parents that, for various levels of coverage and whatever, we're able to do a somewhat cosmetic posterior crown. Selectively in the posterior, I will do a zirconia crown. Sometimes the parents will say, I want the cuspids and the D done in that. That's not bad. Doing a D and an E is much more challenging because of they're bigger, so you can't have any space loss, and there's issues with controlling bleeding. There's subgingival decay and the amount of reduction you have to do with a zirconia crown in the posterior. A lot of reduction is required, so you get into bleeding. Plus, they're not tolerant to being high. If they're high, and it's hard to manage occlusion in a general anesthetic case. It's just not easy to put a bunch of crowns on and get the occlusion 100%. So in a stainless steel crown, if they're high in the posterior, the teeth move a little bit, everything adjusts itself out, it's all good. If you have a high zirconia crown, there is a chance it's going to fracture. And then you're right back at the beginning again, and you're going to have to somehow deal with that fractured zirconia crown. In the anterior, very predictable. I can easily do 6 anterior zirconia crowns in a very minimal period of time, much less than actually even doing a strip crown. Lower anteriors, I'll just say where I can, I try to disc them. I have never done a zirconia crown in the lower anterior because there's a lot of reduction and you got a very small tooth, and they're available. I have never done them. Yes, your next question.
No, I'm actually asking about not indications for SSC or zirconia crowns. I'm talking about very small caries, like
small caries.
Surface.
Well,
yes, on very small caries on canines. Many dentists prefer to make a full coverage.
No.
We all trust full coverage, but I'm talking about these simple situations.
No, in a simple situation, I don't want to do any general anesthesia. In a simple situation, I want to, change the diet where I can, do silver-diamine fluoride and fluoride varnishes, and get the oral hygiene up and see them in 3 months and 6 months. And if they
let's imagine a patient as 3 years old patient with severe decayed
anteriors
and central incisors, but lateral incisors have small caries. Many, but we are treating in general anesthesia. Sure, we're gonna make full coverage for central incisors. What do you do for lateral incisors?
With
small caries.
So if the patient has a significant disability, and the parents and the patient cannot predictably have good oral hygiene, if they've had enormous amounts of decay, if they're from a very high risk population. I'll give you an example. I work in Nunavut part-time. It's an indigenous population. Very difficult access to care, very high caries rates, what I'd call, the highest possible risk. We would consider doing full coverage on all those teeth for all those risk factors. If I have a patient, as an aside, from the time we see them to the time we provide a general anesthetic might be 3 or 4 months. So we have a lot of time to stabilize decay, to work with that family, to see if the oral hygiene can be improved, to get fluoride varnishes in there, to establish a reasonable risk, and talk to the parents. Tell the parents, look, these front teeth, these two front teeth are badly broken down. We can predictably fix them with a zirconia crown to get a great result. And if there's an aesthetic issue where we can't get a very good match between the two central incisors and the two lateral incisors, well, we could put zirconia crowns on the two centrals and two laterals, but they would be for aesthetic reasons alone. For restorative reasons and for predictable success, we wouldn't need to place zirconia crowns on the laterals. On the cuspids, if the caries is very small, I certainly wouldn't be putting, like for instance, buccal caries on a cuspid. If they had a distal lingual caries on an upper cuspid, I'd say, well, there might be an argument for that, because one of the highest failure rates I generally see is those distal lingual restorations that we do on those upper or lower cuspids. But if the caries is minimal, I'm trying to be as conservative as possible, and I don't think there's a formula. We don't just go in and say, we're just going to crown everything. If we can establish true risk, and the parent is in along with us, then we can say, okay. You also have to understand, in Canada, the cost to provide that treatment, for instance, 6 zirconia crowns, one zirconia crown in Canada is $450 Canadian. So you're looking at $2,000 Canadian just to place 6 zirconia crowns based on. So that case, if you're doing all the crowns on the posterior teeth, you're paying for general anesthetic, which runs about $2,000. It's private. It's very rarely covered by the government. You're doing the posterior teeth and the anterior teeth and zirconia. You're looking at $7,000 or $8,000 Canadian. The average parent has about $1,500 of benefits. So that's another part of it. You don't just go in there blithely. Those parents have to, want to have the treatment done, have to understand the risks and benefits, and have to have some pretty deep pockets to want to go ahead with that treatment. Does that help answer the question?
Yes, it's a very nice answer. I'm thinking about the line between minimal invasive dentistry and general anesthesia. Many young colleagues have some concerns regarding this issue. When we are listening to an expert of minimal invasive dentistry talking about SDF, other things, whole technique, our young colleagues say, oh, great. Then they see the cases of general anesthesia with all of the smiles, nice zirconia crowns. They say, oh, this is great. So there's a risk of missing the line between minimal invasive dentistry and general anesthesia. How to decide to put a child on operating room or using minimal invasive dentistry? We know that we should try to understand the patient, the parents, but how to trust the parents? So here's the question. The next question is related to this one. How do you establish trust with young patients and families? Please answer this question with my previous concern about general anesthesia or minimal invasive dentistry.
This is a very important thing. So there's an old saying in the world of sales: you only have one chance for a first impression.
Yes.
So when you meet that family, they've either been referred to you by a general practitioner, or they've read about you online usually, or from a friend, and are making a first visit to you. So it is, our professional obligation is to provide we have to get the diagnostic information, talk to the families, and find out explore the options. Here is, we have the ability, we have everything from minimally invasive dentistry, if the case is selected carefully, right up to general anesthesia. Some parents will tell you, I just want to go in, knock my kid out, and fix all the teeth. And as long as you've explained the risks and benefits of that, and of course there are some significant risks, I think it's an acceptable approach. If the parent says, I want to avoid general anesthesia at all costs, and we have many parents like that, especially ones from Eastern Europe who have a great deal of anxiety about general anesthesia, and I'm sure there's other countries where there have been bad experiences in hospitals and the use of general anesthesia. You have to respect that and look at every alternative. Hall crowns, ART, right? A traumatic restorative technique, SDF. We have so many tools, fluoride varnishes, remineralizing pastes. So my approach with the residents is, what's the rush? As long as the child, if the child's in pain, we have to deal with the pain. If the child has risk infections that are at risk to their health, and I'm not talking about a single abscess, a localized abscess, which many kids come in with, and it's quite stable and will be like that for many years to come. If we can put an atraumatic restorative material on teeth that have some lesions, either just with a glasionomer or a glasionomer and a band, we can stabilize that tooth. Often it'll last longer than somebody attempts to put a resin in that area. If we can put some SDF on those areas, if we can get deal with some of the issues of diet at home and brushing, and over 6 months take that kid who was a little anxious, who wasn't sure of us, and that parent who really didn't know us that well, and build some trust and not rush into a general anesthetic, I think that is a more acceptable approach. But if we have a kid who comes in and they're in pain and there's infections and swelling and their behavior's not that good, well, that almost predicts to us what we have to do. But honestly, anybody who has gone on to Jeanette McLean's website, and if you don't know Jeanette McLean, you should, and she's shown the things that she's been able to do that many of us thought were impossible. And certainly I am in awe of her, and she's taught me a lot about what I can do without filling a tooth and without drilling a tooth. I think that's changed me, her approach and the knowledge that she came about with. Now, I just want to give you a little background. When Dr. McLean did her pediatric dentistry, her advisor for her research was Dr. Wagner, which most of you don't know. And her initial research was on veneered stainless steel crowns.
Sure.
And she's gone from that point to being minimally invasive. And now, it's not for everybody, I understand, but it's another tool that we have, and it allows us to interact with that parent and not tell them, oh my God, your kid needs $7,000 in general anesthesia and all these teeth crowned right away. You know what? There's a couple of teeth there that I'm very concerned about that might need some extensive treatment or extraction, or we might have to stabilize with the short term of antibiotics. But let's get them through that phase. Let's not rush into anything. Let's establish some better hygiene habits. Let's explore the costs and the risks and benefits of different approaches. It's easy to go and for us to go and fill a bunch of teeth. Honestly, I tell the residents, the easiest thing I'm going to teach you is how to do restorative dentistry. You're going to get good at it fairly quickly with a lot of treatment, a lot of fillings. What's going to take a great deal of time is the ability to talk with families, gain their assurance, make them comfortable with the approaches that you have, and let them help guide what the treatment's going to be, and not just tell people what the treatment should be.
Yes, I am very familiar with dear Professor Eric Pieski and Janet McLean. I'm following their research, other things. And our previous guest before you was dear Eyal Simshi, maybe from USA. He's doing some magic tricks and he's doing dentistry differently. Another important figure of minimal invasive dentistry, I think. Thank you very much for letting us remembering these names. You are extremely experienced and you are a very hardworking man. Uh, Here is the question: what keeps your passion alive in pediatric dentistry after all these years? Because we know that children sometimes making us getting mad, the parents. So, what is the secret of your passion?
So I think this is an incredibly important question. And I think you have to recognize that suicide, dentists have one of the highest suicide rates of any profession. This is well known and well understood.
Uh,
Uh, which is, so that's the most visible sign of obviously depression and anxiety.
sure.
Then you have many of my colleagues who have dealt with, and we talk with residents all the time. How do you deal with stress? How do you deal with anxiety? And it's getting worse all the time. In society, our financial stresses, our family stresses, our professional stresses, the demands that parents and patients have on providing expert care with no mistakes. And in baseball, they say if you've got it's a sport where we call if you got a 3.0 batting average, means when you're up at bat, one time out of three you can hit the ball, you're doing very well. And what we're supposed to do with our type A behavior, and every dentist is type A, we are supposed to 100% of the time hit it out of the ballpark. And in your terms, 100% of the time when you're in front of the goal with a soccer ball, you're supposed to be able to hit it past the goalie and get it into the net. And we know those are very unrealistic expectations. So how do you manage that? You have to have a life out of dentistry. You have to have colleagues that you can call and talk to, friends that you can call and talk to, family members who understand the stress that you're under. And this is very difficult for people to understand. And my own staff tell me that they go home after a hard day and they work very hard. They work in a very stressful environment. Not just me, a great team that I work with every day. And their husbands or their spouses do not recognize the amount of stress that they deal with in the day, the angry parents, the crying children. And they say, what do? You just fill kids' teeth. How hard can that be? Even many general practitioners who aren't experienced in working with kids go, come on, you're just filling kids' teeth. What's the big deal? I think they're becoming more aware of how challenging that is. And, I say little teeth, big problems, but, we all have to understand you need hobbies. And I told you when I graduated, I was 23. I traveled the world. I did academic dentistry. I did hospital dentistry. I did university-based dentistry. I was in private practice. I lectured and did CE programs. And I have lots of other interests in photography and I paint my house. I just renovated this room that you see behind here. I did it all myself. I have ways to deal with these things to give me some feeling of gratification outside of dentistry. And if your only gratification comes from dentistry, you're going to not be happy, because it's not, you have to feel gratified and satisfied in other aspects of your life and understand how dentistry fits into that. So I was very fortunate because I'm kind of a Renaissance guy. I just like to do so many different things, and I get joy out of so many different aspects of my life. And I hope other people can find ways that they can find joy in their life within dentistry and certainly outside of dentistry. You have to find that, because you're not going to just, pediatric dentistry is a very stressful profession. You have to recognize that, and you have to be able to find outlets for that anxiety to be able to deal with it. It's very real.
This was an awesome answer. I will show this part to my residents or undergraduate, especially undergraduate students, this part, this answer, because this is clearly the sign of being a mentor. Teaching is sometimes easy, but being a mentor is not so easy. This answer was absolutely great. I can say that. The next question is about traditions and technology, new generation. Here is the question. How do you blend tradition with cutting-edge technology in your practice?
So as you know, I'm only going to answer that from the point of view of what we do with our residents now, because I, I gave up my practice in December. I'm 70 years old now, and I decided it was better for me to walk away from it when I was still feeling good about it, rather than somebody telling me that I needed to retire. And I always told my staff, if you look at me one day and you say, you know me, if I'm not doing what I should be doing and I'm not doing the results I should be getting, you tell me and it's time for me to get out. Because sometimes we don't recognize that we need somebody to tell us. So anyway, I recognized that. I said, okay, it's my time. There's other things I want to do. There's other things I need to, I'm going to enjoy and explore, including more time teaching and more time with residents and CE programs or whatever, traveling, cooking, whatever you want to do.
Yeah.
Do it. So this is I got burned by a number of, quote, very advanced techniques early in my career. The first one was the combined etch and bond that first came out, and I trusted somebody. There wasn't much evidence out there, but he was an academic, and he was a good academic, and he says the work he was doing on it was very favorable. Well, it was a 3M product that used a very mild acid in it, and all my sealants failed within 6 months. And I'm talking, I went and redid every one of those at my own cost, and it wasn't great from a financial point of view and from building trust with parents' point of view, but I went and did it. My second situation was I was involved in testing a new type of restoration for the primary anterior, which was a precursor of zirconia crowns. It was a preformed, it was called art glass, and I was one of the people that was testing art glass on patients. And I have cases. They look beautiful, but they look beautiful for about 6 months. The problem was that like polycarbonate, the bonding of the glue or the adhesive to the art glass and bonding to the tooth were not that adequate, and many of them failed. So after that, and the trauma of dealing with angry parents and et cetera, and having to rectify those, I became a little more reluctant to immediately accept everything that a manufacturer was telling me about a particular product. So like BioFlex, for instance, I'm not using it right now. I think it has its place. I would like to see some in vivo and in vitro and in vivo. I want to see some wear studies. I want to see some clinical studies at least 3 years of use, and then I'll feel much more confident about it. And it's not because I have any particular unhappiness with the product. It's just my past experience is that I want to be a little more cautious. Now, in terms of intraosseous anesthesia and some of the new techniques coming out, absolutely, because intraosseous anesthesia for primary teeth has been well established, but not with these fantastic new like SON, like the SON system, the electronic system. And with Dr. Silva, right? I mean, what he's doing with intraosseous anesthesia, it's fantastic. And I think we're going to be doing a lot of intraosseous anesthesia in primary teeth. It's so predictable in most cases. I think that is an area that we've got a new technology to do it, but it's a very well-established technique that is very successful. So yes, we're going to bring that into our clinics very quickly and utilize it and train students. And I think that's just a more advanced method of doing something that we know very clearly will work. So I'm careful. I'm conservative in bringing in new technology because I've seen momentous failures, especially over the area of composite resonance and bonding, disastrous results, and some of the techniques of building up primary anterior teeth. And it's not, we're doing these things, especially under general anesthetic and whatever on these kids, and if you have to 6 months later bring them in and redo that, it's it's traumatic for the kid, it's traumatic for the parent, it's traumatic for the office. So I'm very conservative in some of these new technologies. Some of them I think are great, and we can see right away that they'll be successful with the results that are provided by the manufacturers. But I'm very reluctant to accept everything that every manufacturer shows to us, and I think that there are people out there that can help us make those decisions a little bit better. Evidence-based dentistry is great, but honestly, most of the evidence is not that great in dentistry. When we look at the evidence in pediatric dentistry, most of what it is, it's our residents in a 2-year program, as part of their studies, have to generate some data in probably 1 year of studies. And that's what most of those studies that we look at are, because the cost of, of doing long-term, studies in children or anybody in dentistry are expensive. And the money isn't out there. There isn't research money from governments. There isn't research money from manufacturers. It's the evidence is hard to come by. So I look at that evidence very carefully before I go ahead and wildly adopt any new technique that I'm not so sure about.
I'm using Sleeper One for digital intraosseous anesthesia, and I will give a lecture next week in Balkan Association of Dental.
Yes, I saw that. Yes.
Yes. It's a very reliable method for.
Absolutely.
So
that's why we're going to adopt that very quickly into our clinical situation, because we can see the science behind intraosseous anesthesia is very well understood. It used to be done with where we would. My old technique was we had to drill a tiny hole in the bone and then inject into the hole with a very short, ultra short needle. And it gave amazing anesthetic very quickly, but it was a little uncomfortable for the child. But these new ones, where they've got the electronic, the precision electronic, that just makes it so much more predictable and so much easier for the clinician and more comfortable for the patient. So yes, there's a winner as far as I'm concerned.
Like 30 years ago or more, 20 years ago, it was done manually. Have you ever done with X-type or Stabident? Have you ever?
Yes, I use Stabident. Yep.
Yeah.
I used
it. How was it? I will tell in my lecture. What was it?
So here was ideally I was using it, and again, we had these children who would come in and we couldn't freeze their 6-year molars, often because it was an MTA type of lesion. And of course, because you got these very wide open tubules, they were very sensitive. I tried nitrous. I tried a couple of, I tried local freezing. And what we did do is I used a Stabident, and we got very, very predictable results with Stabident, because 99% of the time we were getting success using some nitrous and some Stabident in those particular cases. And that's where we realized that we could use this on a predictable basis. Yeah, so yes, it was excellent.
What do you think about, can it replace with mandibular block anesthesia, inferior alveolar, or it is the gold standard? What do you think?
I think that with some more experience and some studies, we'll be able to choose in many cases to use intraosseous anesthesia. There's an old calculation we used to make, and it was called the 25 rule. If you take the number of the tooth and the age of the patient and multiply it, if you got 25 or less, you get predictable anesthesia just by buccal infiltration. And what I meant was, in the FDI system, the E is a 5, the D is a 4, the 3 is a C, and the 2 is a 1. And if the child was 5 or under, and you were trying to establish anesthesia in the E, or the fifth tooth, you'd get the number 25, and you generally got predictable results. And if it wasn't, and especially if you weren't doing a pulpotomy, or the tooth wasn't hot or endodontically related, that changed the formula a little bit. But many clinicians tell me that with some nitrous oxide and infiltration, they're predictably doing, small restorations, predictable restorations in D's and E's and C's, no problem. So to introduce intraosseous makes it even more predictable. Even sometimes a PDL, if the if your buccal infiltration isn't working, you can put a little PDL intraproximally, and you can get some anesthesia there. But intraosseous makes it much more predictable. So yes, I think that it is actually going to change dentistry. It's going to be very predictable, and the kid doesn't walk out. How many patients have we seen that you had a great experience? The kid was fine. You wake him up, you walk, or you finish the treatment. He gets up, and suddenly he goes like this. My face is numb. I hate it. And for many kids, they then went and bit their lip, and it turned a very pleasant experience into an unpleasant experience.
Sure.
And if we can get rid of that, that one negative, I think it's a major breakthrough for pediatric dentistry.
Yes, I totally agree. Another question is an important phenomenon in many countries. I don't know how the situation is in Canada, but in many countries, especially with socioeconomically disadvantageous countries, sometimes parents would like to asking dentists to extract the tooth instead of making any available treatment because of some financial problems or socioeconomical problems or other things. So here is the question related with my concern. What ethical dilemma have you faced, and how did you handle them? Have there been any requests?
So I think that's a very good question. Sometimes a parent will ask us to do something that we're not comfortable with, and it could be for various reasons. For instance, I have many colleagues that cannot do a zirconia crown. They don't have the experience of the training, and the parent says, I want zirconia crowns for my kid. Well, they say, you know what? I don't have that experience. I don't have that training. I'm going to suggest that you see this person who, I'm aware he does this all the time and is very good at it. Some parent will say, I want orthodontics for my child. Well, I don't do orthodontics anymore in my clinic. I did early in my career, but I just, over the years, I couldn't keep up with that and everything else. And I said, I don't do it, but I can send you to an orthodontist. Or somebody will say, I want you to take out my child's tooth, and I look at it, and it's a complex extraction. I can't do that, but I can refer you to a colleague that does. And if a parent says, I want you to take out a tooth, and I look at it and say, this tooth is, pretty easy to restore, I think it's what are the reasons why you want it taken out? And they could give you lots of different reasons. It could be cost. It could be, they don't believe that, fixing teeth is appropriate because they've had bad experiences or whatever. It could be any number of reasons. So you try to address those reasons. And if they still say, I want the tooth taken out, and you don't feel it's ethical, you do the same thing. You say, you know what, this isn't an approach that I feel comfortable with. And I know that's what you want. So I'm going to suggest that you see a different practitioner who may be more comfortable with that, but you might want to ask before you make that appointment if this is something, that they'd want to do, because I don't want you to go and spend money on another consultation and more time off and find out that it's not something that they want to go ahead with. And from the socioeconomic point of view, if you're looking at, let's say, a D that you could extract or fix, how long does it take to do a Hall crown? I mean, could you not offer the Hall crown as an alternative to an extraction? Probably takes you less time to do a Hall crown than an extraction, so you might be able to tell them, look, from a cost point of view, I can offer to fix that tooth and your child will have the function and no pain and no extraction, much less expensive for the same price as an extraction. So sometimes it takes a little bit of creative thinking. Or I can put a glass ionomer in that tooth and with a band around it. It'll cost the same as an extraction, and it will probably last, a certain number of years, and it'll at least give us time to figure that out. So I won't do something that I'm ethically challenged by, but I think creatively, if we can come up with some solutions that work, it might be an approach. And again, when you're on missions, like you go to a third world country and you're presented with these kids with a lot of decay, and you don't have the time to restore a lot of teeth, and you're forced into doing extractions you wouldn't otherwise do, that's a different ethical dilemma. But hopefully, as pediatric dentists, we can offer parents something that will be financially acceptable, and clinically acceptable. But it's a matter of educating the parents as well. But we're all going to face those challenges for sure.
What do you think about being empathic or sympathetic to the patients? What would you prefer, to be empathic or sympathetic?
I'm not even sure. I'm not sure what that means. So but I always look at it, and I always try to respect what the parents want me to do, and the fears and anxieties of the child. And I would say, I have had over the years people that have addressed me, whether it's through RateMDs and these other online places where they got services from me, and they're saying that I traumatized them, and they're now fearful they've been fearful for their life about dentistry, and it's changed who they are. So when you get to be my age, you hear some of those, and I tell you, it's heartbreaking, because I never went into this to do that to anybody, and I never did it on purpose, but that doesn't mean it didn't happen. And I try to explain that to them. I feel bad for them. I apologize, and I say, if I could do it differently, and I knew then what I know now, great. But what we did 40 years ago, what we do now are different. So I recognize that if we do something that doesn't respect the patient's feelings and their ability to tolerate what we need to do, it can lead to a lifelong fear of dentistry. And I always say that we could win the battle but lose the war. And just because we were able to do a particular procedure on a particular kid at a particular time, is it really beneficial to the long-term health and dental health of that child? So I guess I don't know what that means, empathetic or sympathetic, but that's what I see. I've seen over the years that sometimes we won the battle but we lost the war. We have to be aware of that.
Thank you very much. A simple question. You talked about the whole technique. It's very popular. When we place the crown, there is a high occlusion, whether too much or not. What do you think about the tolerance of children towards this high occlusion?
They're incredibly tolerant. So you just have to tell the parent, in this particular technique, the tooth is going to be high for a few days, and but you have to tell the parent, because they're going to be very worried and call you up, and the kid right away is going to complain. So you always tell them beforehand, because otherwise it sounds like an excuse. If you tell them beforehand what to expect, no surprises. So I think the whole technique in selected cases is great. I don't do it routinely, because most of the time I'm doing extensive restorative care in these kids with a lot of broken down teeth. So it's mostly reducing teeth and doing a lot of care at one time. But it has its place, and we do use it in select cases, and it's perfect in many cases. And when I like on the CE program I did on Saturday on stainless steel crowns and pulps, I said, this is an option that you have. And they're going, no, it's not possible. I can't leave behind decay and just put a crown over the tooth. I said, oh, yes, you can. And it's been shown for many, many years that it's sometimes as successful or more successful than doing a pulpotomy in a stainless steel crown. And for many people, they just don't believe it because they're not familiar with the literature. So the familiarity with the literature and the long-term success of this, it's an important thing for us to learn. It's a little bit of humility. Sometimes the simplest solution is the best solution.
Do you make any cutting or crimping this stainless steel crown before placing it, or just?
I just place them. Now again, for people that use straight crowns that they're not pre-crimped, there might be there's some pros and cons to that, and using it in the Hall technique. Once you get a crimp crown, sometimes it's a little bit harder to get over a bulge. And it is not painless, because you're going to push a little bit, and you're going to push into the gingiva. And that's another thing that is a misnomer. People say it's a painless technique. It's not painless. And that's another thing you have to warn. Using a little nitrous or a little topical around the gingival especially, or in a fairly short crown in the mouth, that's a bit of a problem. But I'm not going to spend 20 minutes to crimp this, to trim and crimp this particular crown and place it on. It's a fairly simple technique, but it's not painless, and that is confusing for many GPs to understand. But under the right circumstances, it works well. I only keep stainless steel crowns that are pre-crimped, and sometimes I'll take the pre-crimped crown and I'll take a Howe plier or a bird beak plier, and I'll just unbend some of the crimp, especially the mesial buccal area and especially the interproximal, so that it'll slip on a little bit easier. Will I sometimes disc a little? Like, first of all, if it's a crowded dentition with space loss, I generally won't do a Hall crown. But if there's lots of space, it's easy to do. If there's a little bit of space, putting in a space maintainer for 15 minutes might help a lot. Could I take a burr for a few seconds and break that space if I stay in enamel? Yeah, I could probably do that as well. So, the Hall crown, there's a little bit of flexibility in there. Is a Hall crown, a modified Hall crown. I'm willing to do whatever I can get on there, and we'll make it as easy as possible. But it is a misnomer to say it is painless.
Can you suggest any commercial name for product which is good for whole technique for SSC crowns, 3M?
So,
what do you?
Okay, so the first thing is for cementation of a stainless steel crown, I always use a resin modified glass ionomer. Yeah. So we just introduced Fujisem 2 into the office. Why? But not into the office, into the residency, because it's predictable, it's easy, and it's predictable. It's a paste. The exact amount of paste is always available. You squirt it out and you mix it and you use it. Now, whether you want to use the self mixer that wastes a lot of the material, I don't. I just squeeze out the exact amount of the two pastes, mix them, put them in the crown, pop it on. If you don't want to use the paste and you want to use a powder liquid, again, if you've got a well-trained staff, it's great. If you don't have a well-trained staff, the paste is ideal. If you want to go to the capsules, I find that's incredibly expensive and very wasteful. I don't use them, but for some people that do a stainless steel crown once in a blue moon, hey, it'll give you a predictable mix. So stainless steel crowns, 3M, everybody has access to 3M. As far as I'm concerned, the new Smile crowns are half the price or less and are a superior product. So some people really like, I've never used Hugh Fradiel, they're available. There's Acerta, which is out of the US, which is a less expensive brand as well. I haven't used it, but I know people that do. But the nice thing about New Smile, it's almost identical to 3M, and most people start with the 3M crowns and learn how to use them, so it's an easy switch. The only issue is outside of the United States, there's shipping involved and some time constraints to get the product to you outside of the US. You aren't going to get it in the same day or next day. So for some people, because they got a local supplier of 3M crowns, 3M is their choice. I always use pre-crimped. I don't use crowns where you have to crimp them. I think that's a huge waste of time.
Yes, thank you very much. Please, sorry.
No, those are my experiences with those different products.
Okay. This question is very special. You have many residents. You had many residents, undergraduate students, as I think. Here is the question: how do you mentor new dentists, and what qualities are crucial for success to be a good pediatric dentist like you?
Well, I wouldn't say like me. I think there's a lot of different pediatric dentists that have success in many different ways. Yeah. And what's really fascinating about pediatric dentistry is there's so many different personalities and so many different approaches, and all of them are successful for the right family looking for the right practitioner. Jeanette McLean's practice is wildly different from my practice, but she has a very successful practice with a very unique approach. And I know practitioners that only, almost always do general anesthesia, some that don't use any nitrous, some that do zirconia crowns on all the teeth, which I think is incredible, but I don't have the skill set to be able to do it. So there's many different ways to skin the cat. So what I like to see in a resident is the ability to try different things, to have an open mind, to look at different approaches and look at the literature and talk to different practitioners. And we have many different in our grad program. We have many different people with different approaches, and I say that's the biggest strength of our practice. That in the clinic they hear a lot of different people and a lot of different ideas, and they get to see what fits for their personality. And the one thing that's hardest for many of them to learn is how to work and deal with difficult patients and kids and have some empathy or sympathy, and have that ability to have a dialogue and discussion with parents. So it's interesting because my son is in sales and my brother is in sales, and they both agree you can teach anybody pretty much anything that is receptive and has the ability to learn. But it's very difficult to teach them how to sell if they don't have that ability to relate with people and interact with people. So the quiet, introverted individual is going to have a harder time to have a successful pediatric dental practice or any kind of dental practice than somebody who is a little more outgoing and a little more engaging with people and has some interpersonal skills. So I think that the thing that is the greatest thing that a resident can bring to the table is ability with interpersonal skills. So the hardest thing to teach. Everything else, I think they can be taught. There's one other thing that we talked about before is the person who comes in and says and is given the choice with some dentists of a simple non-interventionist or non-interventionist care versus general anesthetic and multiple restorations. We have a big dilemma in dentistry, and that's income. And when we are looking at a situation and we could make $7,000 on telling a kid that or a parent that we can restore all their teeth and do it under general anesthetic, or we could make a few $100 placing SDF and placing some glass ionomer. This is a very big ethical dilemma on the part of dentistry. And it may be in some places where you're incredibly busy and you could see 1 million patients, it's not as big of an ethical dilemma. In places where you're not that busy and that case at $7,000 could make it or break it for the week for you, this creates a very big issue for us. And that's the other part of the equation we don't talk about too much. What are the ethical dilemmas of making those decisions where you have an incredible financial incentive to give a very complex treatment plan where you'll make a lot of money versus doing very minimal treatment? And I know you as an academic have made tremendous sacrifices to be that academic, and you're not in the pursuit of an income, but some of the people you've trained over the years, they're driving Mercedes, they're living in the finest parts of town with the biggest houses, and they're taking vacations. And you're lucky if you can scrape up enough money from some kind of a program to get to the IAPD that year. And this is a very challenging part, the part we don't talk about too much. And that's part of part of the conversation as well. And that's a really difficult one. Our ethical dilemma in terms of presenting treatment that is very remunerative to us versus not being remunerative. And how does that sway our particular approaches to patient care? Anyway, I just wanted to throw that out because we kind of talked about it before, but not from that perspective.
Yeah, an excellent comment and excellent vision. Thank you very much for being such a great man. It was a great talks. Thank you very much. I would like to thank you not only being a great clinician, not only being a great educator, but also being a great mentor. We never met in face to face,
No,
but
we haven't, and it's so sad. Will you come to the American Academy of Pediatric Dentistry meeting this year in Toronto? Will you be able to make it?
yeah, I would like to come, but I have two children. They are too small, and
Yeah.
America is too far. I would like to come, but
We're going to meet somewhere, you know,
yes,
and
I'm,
we're
I'm
going to
sure.
have fun.
I'm sure we're gonna meet. I feel that, and this is one of my really. I'm saying with my heart these words. One of my most proudest and most important day for me because uh, I admire your work. Uh, Being a mentor is not about teaching or giving knowledge to colleagues, but giving a vision. And I can say that as we can see in social media, within the forum, you are the most visionary pediatric dentist, and I'm sure that all members of Pediatric Dentistry Forum or Facebook are waiting your comments about cases or treatment approaches or other things. This is amazing. I'm
You know,
very
I never thought about that. Honestly, I did it on a whim. A friend of mine said, "You should join Pediatric Dentistry Forum." And I said, "What's that?" And he introduced me to it. And you know what? I've had such pleasure from doing that. And I, when I was presenting at AAPD last year in San Diego, it was just a 15-minute presentation, but afterwards I had a number of people that came up to me that said that they met me through this particular forum and they really appreciated me, including some that there's this lovely academic from I think Lebanon, and she was doing some research on zirconia crowns, and she was doing this scanning and making crowns with this 3D processes. We had never met, but she had read about the things I was saying, and she just said it was great. So yeah, like I never understood what that how that would impact other people, and it was just a funny thing that I started up, and I enjoy doing because I have the time because I'm semi-retired. And you're not the first person to say that they enjoy listening to my comments and that it's helped them in their field. So that's kind of crazy for me that it was just a bit of a random thing, and it's brought such pleasure to people. I'm so happy for that.
Firstly, we should send our regards and thanks to the friends who have offered you, who have told you to join Pediatric Dentistry Forum. You have a huge impact on pediatric dentists from all over the world. I can say that, and I'm sure that many colleagues are making screenshots your comments to get into the brain. Thank you very much for being a wise man of pediatric dentistry. You are the wise man of pediatric dentistry. You should keep shining. You should be very active on social media. Please keep on doing comments. Please keep on sharing your great knowledge, great experience, and your vision. The most important one is that your vision. So I'm very honored. I'm very happy to have chance to talk to you in CPD talks. I know that I asked too many questions.
No, it was so much fun. And you know, your vision, I mean, I know the amount of energy it takes to be an academic and how thankless it is. How thankless it is for many, from especially the economic point of view, and the amount of work that you have to do and responsibility. And most people don't know that because they haven't been in academics. But you've gone so much above that. I mean, you got tenure, which I know is incredibly difficult to get. You take time away from your family to do this when you don't need to. You feel that this is what you have to do. And I thank your family for allowing you to do that, because I know how hard it was for my family when I had to do things that it took away from being with them. So this I respect what you do. That's why I'm involved with you, and why, whenever you've asked me to come and do something, I've welcomed it with open arms, because I think we see the world in the same way. We're here to give, and we don't want to take from our families. There's some sacrifice they give up, but we want to do good in the world, and we try to do that. And it's so much fun to meet other people like that. And if you ever get to meet Bill Wagoner, and in person, or Ari Kupetsky, and there are others I could go on and name, these are some of the most amazing people and nicest human beings you'll ever come across. They just have given and given and given to the world. And of course, Anna Fuchs, who now, I don't know if you know, her husband just passed away, and she's just gone into long-term care. She's not that well, but she's given her heart to this world, this little world that we live in, that really nobody else knows much about. But we have to respect those people who have done it, because we're the only people that know. It's a little secret we have, and it's amazing that you've done that. And hats off to Diane Kruger as well. Have you ever met her? I don't know. She's the president of New Smile.
Yeah, I know.
She made New Smile.
Yeah.
So the sacrifice that she made as a woman to run this business by her, basically single-handedly and ethically, and start with nothing and turn it into a company that is providing fantastic materials and service and a dedication to pediatric dentistry. It's people like that that make the world go round. And we need to mention their names so people don't forget who they are. Anyway, thanks again. I've taken up enough of your time. It's been a wonderful afternoon.
Thank you very much. I'm very appreciated with your contribution to the CPD talks. I also am special thanks to my wife, to my two children, to my friends Khan, Fatih, and Mehmet Ali. Thank you. I would like to thank them for their technical support and other things. And I'm sure that we will meet in next events, in face-to-face events. We always would like to listen to you, and I'm sure that we're gonna meet in the next events. Thank you very much for sharing your time and for being with us. I'm really very honored. Thank you very much. Bye-bye.
Okay, bye-bye.
Bye. Dear colleagues and friends, good morning, good afternoon, good evening, good night for everyone, and thank you very much for viewing us. The record will be live on YouTube, and you have chance to watch afterwards. So, bye-bye to all of you. Thank you very much.